Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We pick up page 216 for this 36th edition, September 14th. We want to give a thanks and great honor to our friends and family. Kendrick Lamar Mosley. Thank you. Thank you so much. You have given the world such beautiful children, and now you have a grandchild. Highest heart love. You are the highest heart love. Thank you, Kate. Thank you so much for everything you did for us in the world. You set so many people on a path of love over hate. The great Nasir Jones, inspired me in so many ways and so many others. The GOAT, we salute you. Thank you so much for all you have given to all of the world. Your beautiful rhymes and harmony, it's just a magnificent person for us to listen to and get guidance from. A master, true master MC. Thank you so much for being here. September 14th, we begin at the top of page 216 on clinical application of respiratory care, chapter 13, pharmacology in bronchial hygiene therapy. Corticosteroids. Corticosteroids are clinically effective in relieving bronchospasm, especially in status asthmaticus. The specific actions affecting the bronchodilation are unknown. Cromolyn sodium. Cromolyn sodium is a new agent whose main value is as a prophylactic bronchospasmolytic in allergic asthma. It has been reported to allow steroid-dependent patients to significantly reduce steroid dosages or completely discontinue the drug. The mechanism is believed to be the stabilization of the cellular membranes of mast cells. These cells are in abundance in allergic asthmatics and release histamine and other agents which induce bronchospasms. Cell wall stabilization is believed to decrease the release of these substances resulting from antigen antibody reactions and thereby decreasing the bronchospasms of the allergic asthmatic. This drug is of no use in the treatment of acute bronchospasm. It is a preventative. It is available as a powder and is inhaled with a special spinhaler. The usual dose is 1 capsule 4 times a day. If the patient improves sufficiently, 1 capsule per day may eventually be adequate. Decongestants. Thank you so much for being here. Thank you, highest heart love. Peace. Decongestants. Middle of page 216. Hi, it's Heart Love live from the light here in LA. Thank you so much for being here. Nasal and pulmonary tree epithelium have a potential for copious capillary blood flow. When mucosal capillaries are dilated with maximal blood flow, they are said to be congested. This mucosal congestion can lead to significant swelling of the mucosa, increasing airway resistance and causing nasal obstruction. A medicine that relieves this congestion is called a decongestant. True decongestants are alpha adrenergic adreneric drugs that cause arterioles to constrict, thereby decrease blood flow to the area. This decreased blood flow diminishes capillary hydrostatic pressure and decreases fluid transudation to the tissues. Allergic decongestants interfere with histamine like irritation of tissues and thereby diminish the cause of the increased blood flow. Corticosteroids are commonly used as decongestants because of their anti inflammatory action. All right. Phenylephrine, neosynephrine. Phenylephrine neosynephrine is the most commonly used oral decongestant. It is most often used in the liquid form in combination with antihistamines. Pseudoephedrine is a stereoisomer of ephedrine that is reasonably good mucosal decongestant with a little alpha side effect. Although far more useful as a nasal decongestant, it is often used for therapy of the pulmonary tree. Antihistamines. Antihistamines, e.g., Benadryl, chlortrimeton are very effective for nasal decongestion when the congestion is of an allergic origin. Antihistamines decrease glandular secretion and may have an effect of thickening the secretions. That's very key, right? Thank you so much for being here and reading with us. Guys, Heart Love. Clinical application of respiratory care for respiratory therapists that are aspiring and people aspiring to take the MCAT. This is the information where we get $1,000 of information here for free. You know, we're reading along and we're in chapter 13. Thank you so much. We're pushing to 1,000 subs on this channel where we read books and learn from masters, the peaceful part of YouTube. So thank you so much for being here. Mucokinetic agents or expectorants. Mucokinetic agents are used to help improve the removal of sputum. Most of these drugs are probably no better than water, which is an extremely effective agent for thinning mucus and decreasing its viscosity. Water may be administered by mouth, veins, rectum, or inhalation therapy. Nebulization is generally considered to be the most effective method for the administration of saltwater solutions for the thinning of retained secretions. Aerosolized, aerosolized mucolytics will be discussed later. Here we are concerned with the systemic mucokinetics. These agents fall into two general categories: vagal stimulants and direct bronchial gland stimulants. Vagal stimulants. Ding! Vagal stimulants work by stimulating the gastric mucosa causing reflex vagal activation of the bronchial glands, producing secretions. Glycerol, guaiacolate, robitussin, and terpene hydrate are common expectorants that work via vagal stimulation. Direct bronchial gland stimulants. Direct bronchial gland stimulants are exemplified by supersaturated potassium iodide solution, or SSKI. When administered orally, this solution has a direct effect on the bronchial glands, causing increased secretions. In terms of respiratory therapy, the use of the oral expectorants appears self defeating. A primary purpose of aerosol therapy is to decrease irritation to the pulmonary mucosa while improving and promoting mobilization of secretions. Although expectorants are widely used in general medicine, they are of no benefit in respiratory therapy. Anti inflammatory agents. Corticosteroids are used to decrease acute chronic inflammatory processes of the pulmonary tree. The specific mechanisms are unknown, but there are many patients who obtain significant relief from no other regimen. Anti allergic agents. Allergic disease is responsible for a significant portion of pulmonary disease. Many patients are dramatically relieved by hyposensitization regimens, allergy shots. Antihistamines are useful in documented allergic disease, but must be accompanied by efforts to maintain fluid secretions since these drugs tend to dry the mucus. Corticosteroids are also used as anti allergic agents. Anti infectives, antibiotics. The application of antibiotic therapy for documented pulmonary infection is a well tested mode of therapy. The greatest hazard is in the misuse and abuse of these excellent agents. Antibiotics are the most widely used category of drugs in pulmonary disease, with exception of the bronchodilators. Antitussives. Codeine is the most popular anti cough agent. It is a potent central nervous system depressant of the cough center. This may be very useful agent for the mildly ill home therapy patient. However, in respiratory therapy, the emphasis is placed on making the cough productive rather than suppressing the cough. Very key, right? With antitussives. Says codeine is the most popular anti-cough agent, but instead of suppressing the cough, we want to let it out. Same way with the sneeze. Why? Because that allows the mobilization of, yes, that's right. That's right. We want to keep mobilizing the secretions to get them out. Something very important. I'll share this gem, especially since it's gem time day. So, my daughter, she's 19 now, right? She remembered when she was a little girl, and I would tell her, Isis, spit it out, get it out. Don't swallow it, spit it out, right? And she was 17 and, you know, getting ready to graduate high school, and we were celebrating. And she was like, "Yeah, Dad, I don't really get sick. Always remember you telling me to spit it out, get it out." And I was like, wow. Respiratory care. That's the lesson. Inhalation pulmonary agents. The topical application of pharmacologic agents to the pulmonary tree is a well accepted mode of therapy. In many circumstances, the drugs are more effective by the inhalation route, and in other cases, they are used only as an adjunct to systemic therapy. We shall discuss in detail the bronchodilators, decongestants, and mucokinetics. These are major categories of aerosolized drugs must be completely understood by the respiratory care practitioner, both in their pharmacologic action and in their technical administration. Catecholamines, bronchodilators, isopropanol or isuprel. Isoproterenol is the classic beta adreneric bronchodilator, a derivative of epinephrine. It was introduced into the medical arsenal in 1940. It is the most powerful bronchodilator marketed in the United States today, and its use with IPPB has been extensively experienced over the past 20 years. Only about 10% of the drug administered into the lungs by nebulization is retained. The degree of bronchodilation is dependent upon the systemic blood levels obtained. Page 219 at the top. Isoproterenol is a powerful beta stimulator without an alpha effect. Thus, it will cause vasodilation of the pulmonary mucosal vessels. This not only increases airway resistance, but results in an increased mucosal blood flow with consequent rapid absorption of the drug. The resultant effect is in relatively short persistence of the bronchodilating action with a marked tendency for cardiac beta 1 side effects. Tachycardia, palpitation, and flushing of the skin are common side effects of aerosolized isoproterenol and often given as reasons for patients not tolerating IPPB therapy. Our guideline for the IPPB maximum safe adult dose of isoproterenol that may be administered via an aerosol is 5 milligrams administered over a 10-minute period, repeated no more than each hour. The preparation comes in either a 1 to 100th or 1 to 200 solution. Since 1 milliliters of a 1 to 200 solution would contain 5 milligrams of isoproterenol, 1/2 milliliters of 100 or 1 to 200 isoproterenol would contain 2.5 milligrams. This is the routine recommended dosage diluted at least 3 times in the nebulizer. This is 50% of the IPPB maximum safe adult dosage and is extremely effective in most patients. Isoproterenol is a potent and reliable bronchodilator, but demonstrates the pharmacologic principle of tachyphy- tachyphylaxis. This is the phenomenon of less and less response to increasing doses of a drug over a period of time. In addition, its action is far less effective when acidemia is present. Uh, Isothyrein or bronchosol. The recently introduced catecholamine isothyrein has become very popular because it has little beta 1 effect in relation to isoproterenol. However, it does have beta 1 effect and should not be considered a pure beta 2 stimulator since large doses result in tachycardia. This is very key, right? Wow. Remember, tachycardia is rapid heart rate. Peace, Marquise. Highest heart love. Thank you so much. Still working? Yes. Love you too. Highest heart love. Gratitude. The mods is in the building. Thank you so much. And we're on page 219 for those in the playlist and reading along. Clinical application of respiratory care. Here we go. It is a less powerful bronchodilator than isoprotanol, but nonetheless, it is clinically effective. Isothiorine is available in the United States. Isoethylene is available in the United States under the trade name of Bronchosol, which contains 1% of isoethylene. Our IPPB maximum safe adult dose of isoethylene is 5 milligrams given over a 10-minute period, repeated no more than each hour. It is recommended that a half milliliter of bronchosol be diluted 3 to 5 times in the nebulizer and administered every 2 to 4 hours. Wow. We'll pause right here because I want to go into want to let it sit in, you know. You have to continue. Now get away. Thank you so much for being here. It's so peaceful. So peaceful. Thank you for reading with me. Thank you for breathing with me. Love to Kendrick. Love to the great Nas. Highest heart love. Thank you so much. Thank you for being here. Thank you. This is a peaceful place of YouTube where we read books and learn from masters. So we just left off at page 219 down at the bottom of clinical application of respiratory care. This part of YouTube where we shake it up by reading books, learning from masters. Master information makes a high level being, right? And we're the light workers here. So join us. Join us. Thank you so much. You know I love y'all. Yeah, we're doing it. We're doing it. You know, it's highest level. So take, let it sit in. I'll put the vocabulary in the description, right? Yeah, only the best. Thank you so much. Always love. Oh, so we're going to have a drink of love water, right? Yes, thank you so much. So much love, much appreciation. I love you. Thank you for being here. We love you, Nas. We love you, K-Mo, Kendrick, Mosley. You're the Thank you so much, Kamo. We made love over hate out. Love you. Mm. I love you. 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 Thank you. I love you. I love you. I want y'all to have a wonderful, wonderful evening. I'll see you in. You're going to now. Okay, so I was thinking indigo, but then it was like, no. um, let's clean it all out, right? Let's go to the white cloud tonight, okay? So I'll see you there, resting comfortably. Want you to have a wonderful evening. Light workers, we are uniting and giving it to us, right? I'll see you soon. Peace, peace.